Hello, wonderful staff of the Northwest Kidney Center. I'd like to begin by reflecting on the incredible year that we've had as an organization, particularly at the flagship unit in Kent. Did I mention that the Kent Northwest Kidney Center is a 5-star dialysis facility? And that's 5 out of 5, not 5 out of 10, in case you're wondering. And for the scores of you who have applied to work at the Kent unit, we're still reviewing your applications and hope that all of your professional aspirations and dreams come true this holiday season. Today we're going to talk about eating on dialysis. Is it good? Is it bad? Should it be allowed or even encouraged? Or are there enough potential health concerns associated with eating to justify us in discouraging our patients to eat? So don't go away, because I know all of you love literature reviews, and that's what you're going to get this hour. There are 3 objectives to today's talk. Understand the historical evolution of the opinion regarding food consumption on dialysis. Understand the potential hazards associated with eating during dialysis, and recognize the potential nutritional benefit of eating during dialysis. First, a little background on dialysis and nutrition. When maintenance dialysis began in hospitals in the 60s, dialysis was very inefficient, which meant long treatment times, up to 12 hours, and therefore units provided meals. By 1976, the standard treatment was 8 hours of dialysis 3 times a week, and patients ate a meal they brought if they were not provided one. But as dialysis became more efficient in the 1970s, late 1970s, treatment times were shortened, and with more rapid volume and solute removal, there emerged the problem with hemodynamic instability, particularly hypotension. And hypotension seemed worse among patients who had recently eaten, and there were some studies that showed that after you eat, there occurs a reduction in your systemic vascular resistance, and that was likely the mechanism. So dialysis units began discouraging patients from eating. And there were other reasons for discouraging eating as well. There were isolated cases of aspiration during dialysis, which led to some lawsuits, and in general, dialysis units don't like to be sued. There was also concern regarding reduction in dialysis efficiency. So we might not clean the blood quite as well when dialysis patients eat. And finally, a lot of dialysis patients already have nausea and vomiting or other GI symptoms, and eating appeared to exacerbate these symptoms. So based on these observations, many dialysis units in America began to decide to ban eating on dialysis. But that's not necessarily the trend for the rest of the dialysis world. In European and Asian dialysis units, for example, a much larger percentage of these units provide meals for their patients or allow patients to bring their own food. In a 2014 cross-sectional survey, 84% of dialysis clinics from 6 continents allowed patients to eat during the dialysis treatment. And in fact, 73% actually provided a meal to the dialysis patients. And one unit in France, for example, was known for providing a very fine French meal as well as wine for the patients during dialysis, minus, of course, the French cheese because of its high phosphorus content. This contrasts with dialysis facilities in North America, particularly the United States, which feature a much more restrictive in-center nutrition policy. A 2016 survey of a large dialysis organization in the United States showed that up to 29% of dialysis clinics in the United States outright ban eating during dialysis. I briefly touched on some of the reasons why. Now we'll go into more detail why a lot of U.S. dialysis units have historically discouraged eating on dialysis. So what are the problems with eating on dialysis? As I mentioned just a little bit ago, the main problems, which we'll discuss in detail, are intradialytic hypertension, so low blood pressure during dialysis, decreased efficiency of dialysis or reduced solute clearance, and exacerbation of common GI symptoms such as nausea. So intradialytic hypertension or low blood pressure during dialysis is a very common problem. occurring, depending on the study, anywhere from 5 to 40% of all treatments, and it can either be symptomatic or asymptomatic. There's a formal definition of symptomatic interdialytic hypotension. It has to feature an abrupt fall in systolic blood pressure, symptoms such as cramping, headaches, nausea, or vomiting, and 3, requires some sort of medical intervention, some response from the dialysis staff, and that may include, saline or even stopping dialysis. Low blood pressure is uncomfortable and it's potentially dangerous for a dialysis patient, so we take it very seriously. Interdialytic hypotension can be exacerbated by eating. That drop in blood pressure after eating, so the so-called postprandial drop in blood pressure, it's particularly common in older diabetic patients who so frequently are present in dialysis units. Why does blood pressure fall during dialysis? Well, for starters, when you eat, the intestines need more blood, and so blood gets shunted away from the periphery, such as your arms, your extremities, to the intestines. So there's less blood, going through your extremities, and of course we use blood coming from the fistula in the arm. And second of all, intestines release so-called vasodilatory molecules. These are molecules that dilate the blood vessels during digestion. A couple of observational studies have looked for an association between oral intake and blood pressure. One was published by Benaroya in 2008, a retrospective study of 126 hemodialysis patients who routinely eat during dialysis. They actually found no correlation between oral intake and blood pressure, and no difference in oral intake on days where interdialytic hypertension did occur. Strong published a study in 2001, a retrospective study of 23 dialysis patients who routinely eat. Overall incidence of hypotension was low in this study, and they found that hypotension, defined in their study as a systolic blood pressure less than 90, occurred more often when patients consume more than 200 calories during the treatment or consume more than 200 milliliters of fluid. They found no difference in symptoms such as cramping associated with eating. Numerous intervention studies have also been performed to look for an association between eating and hemodynamic stability. Sherman published a study in 1988 of 9 hemodialysis patients, half of whom were given a standard meal halfway during the dialysis treatment, and they noticed a significant reduction in blood pressure just after the meal. Zoccali published a study in 1989 looking at 13 dialysis patients and reported more hypotension, including symptomatic hypotension, in the time after the meal. Sivalingam published a study in 2008 of 20 hemodialysis patients given a standard meal 45 minutes into dialysis. Noticed a significant reduction in mean arterial pressure 30 minutes after food intake. Shibagaki in 1998 published a study of 23 hemodialysis patients given a meal during the treatment, and 16 of the 21 received a meal when they were basically in the supine position, so lying flat, and 6 were seated upright. And they found that relative blood volume drop was less in the periphery when patients were lying down as opposed to sitting up. So the combination of eating and sitting upright was associated with more hypotension. And Barak published a study in 1983. Dialysis patients were fed a standard meal after the first hour, and they noticed a significant reduction in blood pressure and systemic vascular resistance, and a lack of compensatory increase in cardiac output. But not all intervention studies have shown a drop in blood pressure. So for example, Kara in 2010 looked at 25 stable dialysis patients fed a standard meal and witnessed a transient reduction in blood pressure, but no difficulties with symptomatic hypertension. And Mueller-Deal in 2014 looked at 40 stable dialysis patients who were fed a standard meal. They found no reduction in systolic blood pressure, diastolic blood pressure, or mean arterial pressure after meal ingestion. The second concern we'll look at is the potential for eating on dialysis to compromise the solute removal or the efficiency of cleaning the blood on dialysis. A couple of mechanisms have been proposed. If patients have symptomatic hypertension, it may lead to earlier treatment of dialysis, and shortened dialysis treatments reduce the amount of time to remove solutes. And second of all, as we talked about earlier, when you eat, the intestines need more blood, and so you sequester or you pull blood in towards the digestive tract, and this minimizes the blood in the periphery, say where your arm and fistula is, to be dialyzed. So you reduce the concentration gradient between the blood and dialysate, and you remove less solute. Let's look at some of the studies that have examined the effect of eating on dialysis efficiency. So there was a study by Singri published in 2004 that looked at the effect of eating before dialysis on adequacy. So they compared the efficiency of a single dialysis treatment after a 3-hour fast to those who ate a meal 2 hours before the start of dialysis, and they found no difference in your urea reduction ratio or the KT/V. So eating before dialysis does not appear to affect adequacy. Eating during dialysis is different, though. So Kara published a study in 2010, 25 non-diabetic hemodialysis patients in 2 consecutive midweek sessions. So during one of the sessions, they were given a standard meal, and the other session, they were not given a meal. And they reported that feeding during dialysis resulted in a significantly lower urea reduction ratio and KT/V compared with the fasting dialysis treatment. San Juan Miguel Sanz in 2001 compared standard dialysis with dialysis in which patients were not allowed to eat, and also noticed a reduction in dialysis efficiency when patients ate. The third concern with allowing patients to eat on dialysis is its exacerbation of intestinal symptoms. So GI symptoms may worsen when eating during dialysis. And this occurs in a population in which there is a greater prevalence of GI symptoms in the general population. So GI symptoms, including nausea, are thought to occur in about 10% of all treatments, and there's potential that eating could make this worse. Now, nutritional supplementation studies, how we give Prostat to dialysis patients, have actually tracked GI symptoms and reported incidences similar to or below these estimates. So it doesn't appear that a nutritional supplement given during dialysis exacerbates symptoms. And there have been no randomized trials looking at the effect of eating during dialysis on GI symptom frequency or severity. Now let's go ahead and look at the potential benefits of eating during dialysis. In 2007, the European Best Practice Guideline Group recommended that oral food intake during or just before dialysis should be avoided as a preventative measure against low blood pressure during dialysis. But in 2018, the consensus statement of the International Society of Renal Nutrition and Metabolism recommended the opposite, that the administration of meals and supplements during dialysis should be pursued to improve nutritional status and potentially clinical outcomes. So why the change? First, there's a growing appreciation of the fact that nutritional status is a very important predictor of outcomes in maintenance hemodialysis patients. So low albumin is a strong predictor of mortality in the dialysis population. In fact, Frank Fung, the medical director of the Renton Northwest Kidney Center and researcher extraordinaire, published a study in 2002 that for every 1 gram per deciliter albumin is below normal, mortality increases by 35%. Second, hemodialysis is a highly catabolic condition. Large number of dialysis patients suffer from so-called protein energy wasting, and a lot of dialysis patients lose lean body mass every year, and that contributes to their frailty. Some protein is also lost during the dialysis procedure, so there are amino acids that are floating in the blood, and these diffuse out of the blood into the dialysate. Finally, the Kidney Disease Outcomes Quality Initiative, or KDOQI, recommend increased caloric and protein intakes for dialysis patients, but these goals are very hard for patients to meet, and they're usually unmet. And also, research has shown that dietary intake tends to be lower on treatment days compared with non-treatment days. And this is especially true in patients who do not eat during the dialysis treatment, suggesting that this may be an intradialytic window of opportunity for us to help our patients achieve the therapeutic target to improve nutrition intake. So there's recognition that intradialytic nutritional support may improve nutritional status. So allowing patients to eat or consume supplements during dialysis might be an effective strategy to improve nutrition status on treatment days. There are several studies that have been published on intradialytic nutritional supplementation that have been shown to improve nutritional reserve, how patients feel, and biochemical markers such as albumin and prealbumin. For example, there's a study by Marson published in 2017. It's a multi-center, open, prospective, randomized trial of 107 hemodialysis patients who demonstrated clinical evidence of protein energy wasting. So the intervention group received nutritional counseling plus intradialytic parenteral nutrition 3 times a week over 16 weeks, and they saw a significant increase in mean serum prealbumin, which is a biochemical marker of nutritional status. And this is why the Northwest Kidney Center and many other dialysis organizations provide protein supplementation during dialysis. There is growing concern that restriction of eating on dialysis may contribute to the development and potential worsening of malnutrition. And part of this relates to the fact that a 3 times per week dialysis pattern may interfere with regular meal consumption. Burroughs in 2003 looked at data from the HEMO study, which included 1,900 dialysis patients, and reported that food consumption was significantly lower on treatment days than non-dialysis treatment days. And Rivline published a study in 2009 using a continuous glucose monitor and showed that the mean glucose levels were lower on treatment days, and there were more episodes of asymptomatic hypoglycemia on dialysis days than non-dialysis days. Chu published a study in 2013. It was a retrospective cohort study looking at United States dialysis patients from 2006 to 2008. There were 470 dialysis patients who were considered at high risk for protein energy wasting based on a serum albumin of less than 3.8. 276 of these patients were given nutritional supplements, 1 can of Ensure per day. 194 patients either refused the on-dialysis nutritional supplement or, for various reasons, were deemed inappropriate to receive it. They reported a minimal increase in serum albumin with protein supplementation. So you're looking at maybe increasing the albumin from, by 0.1 grams per deciliter, like 3.6 to 3.7. So not a very big increase in serum albumin with nutritional supplementation. But interestingly, there was a reduction in probability of being hospitalized. So you can see the supplement group had a greater probability of not being hospitalized than those who did not receive nutritional supplements. Somewhat impressively, they also showed better survival among patients who received supplements than those who did not. Another study that supports the benefit of nutritional supplementation during dialysis is called the FREDDY study, or 2012. It is an acronym that stands for Phosphorinol for Enhancing Dietary Protein Intake in Hypoalbuminemic Dialysis Patient Study. This study identified 110 hypoalbuminemic dialysis patients. They had a serum albumin of less than 4. Half of them, 51 patients, about half, were given these lovely meal boxes every treatment for 8 weeks that had high protein, low phosphorus content, in addition to phosphorinol to control or minimize the absorption of phosphorus from the meal. The control group, 55 patients, received low-calorie meals containing almost no protein, so they were given like a salad during dialysis. Now, it's nice to receive a salad during dialysis, but if I had seen my neighbor eating this lovely protein-rich, sandwich or something like that, I think I would have been annoyed. Patients were followed for 8 weeks. Now, what did the study show? The main endpoint was a rise in albumin at least 0.2 grams per deciliter while maintaining phosphorus between 3.5 and 5.5. The endpoint was achieved in 25% of the intervention group and only 9.8% of the control group. There were no adverse events associated with eating, and there was significant patient satisfaction associated with the high protein meals. The authors did not comment on the emotional satisfaction of those who received the salad. A meta-analysis of 15 randomized trials totaling 589 participants examined the benefits and harms of oral nutritional supplements among patients on hemodialysis. Compared with control groups that received a placebo or just usual care, such as a salad, oral nutritional supplementation was associated with a modest improvement in serum albumin levels, average 0.16 grams per deciliter, and a slight increase in body mass index. Now, whether or not this improvement in nutritional status is translated into net clinical benefits remains unclear, since none of these trials included in the meta-analysis reported treatment effects of oral nutrition supplementation on hard clinical outcomes such as mortality or hospitalization. Okay, let's summarize what we've learned today. Hemodialysis is a catabolic procedure which has potential adverse consequences, including malnutrition, either because of amino acid loss during the procedure or by interfering with the consumption of food on dialysis days. Concerns about eating on dialysis include low blood pressure during treatment, reduced dialysis clearance, and exacerbation of GI symptoms such as nausea. Most studies, however, suggest that interdialytic hypotension associated with eating is transient and generally well tolerated. The administration of interdialytic nutritional supplements represents a clinically and financially feasible strategy to improve nutrition uptake. I hope you all have been paying attention because it's time for the quiz. Question number 1, this famous nephrologist published a study looking at the impact of low albumin on mortality. That's right, the famous Frank Fung. Question number 2, name 2 potential concerns with eating on dialysis. That's right, so intradialytic hypotension, reduced dialysis clearance, and exacerbation of GI symptoms such as nausea and vomiting. Question number 3, how does dialysis contribute to malnutrition? That's right. Amino acids are removed during the dialysis procedure. Dialysis patients eat less on dialysis days, and dialysis patients are generally catabolic. Question number 4, does protein supplementation on dialysis increase serum albumin? Answer is yes, although minimally. So you might see a rise in albumin by 0.1 or at most 0.2 grams per liter. Question number 5. Does the consensus statement of the International Society of Renal Nutrition and Metabolism support eating on dialysis? And the answer is yes, with the goal of improving nutritional status. This concludes the December 2023 monthly in-service for the Northwest Kidney Center. I hope all of you eat a lot of healthy food this holiday season and have a wonderful time with your families. This is Andy Borkenbrough signing out. Until next month.